Good morning, everybody. We announced at the beginning of our session, this is under the name of assisted reproduction, embryo freezing. We start our session by a recorded video, a presentation by Dr. Madelon Van Wely. She's a clinical epidemiologist and assistant professor specialized in human reproduction, University of Amsterdam and Holland. A presentation about fresh versus frozen embryo transfers in assisted reproduction. It is a recorded video.
Good afternoon. I'm really happy to be here online, and thank you for inviting me at your conference. My name is Madelon Van Wely. I'm a clinical epidemiologist working at the University of Amsterdam, the Amsterdam University Medical Center. You see a part of the building behind me. It's like I'm standing on the parking lot right now. I hope next time that I will be able to visit your country again. But now it's COVID, and that was just not an option to travel. My main interests are really into anything on fertility. I'm very actively involved in many RCTs, in several cohort studies. I am involved in Cochrane reviews, in Cochrane Gynecology and Fertility group. I'm also deputy editor for human reproduction. And well, today I'm happy to talk about the freeze-all strategy versus a conventional fresh embryo transfer strategy. Now I'm going to share my screen. So this is my conflict of interest. I'm involved in Cochrane, leading the satellite of the Gynecology Fertility Group. And well, I just told you I'm also deputy editor for human reproduction. I will first present a bit on the Cochrane before moving on to the actual Cochrane review. So the Cochrane collaboration is an international non-profit organization that prepares, maintains, and disseminates systematic up-to-date reviews of healthcare intervention. And it was named in honor of Archie Cochrane, who was a British researcher, and who came up with the idea to summarize all evidence that we have to get a better overview, and well, such that we can all use this evidence worldwide. So now we have this really large Cochrane organization. So we have 50 review groups with one overarching steering group, and review groups get input and help from national Cochrane centers, method groups, consumer groups, and other fields. And the gynecology and fertility group that I'm heavily involved in is one of those 50 Cochrane review groups. And we produce, like the others, systematic reviews relevant, of course, for us in our fields on gynecology and fertility. And I thought maybe for you, when you would like to get involved in Cochrane reviews, it's good to know that when people want to undertake a Cochrane review, it starts by registering the title. The editors of our review group will check whether the title does not overlap with already present titles. And when a title is registered, a protocol is written and published. And after that, the full review is started. A Cochrane is updated like every 2 to 5 years. Cochrane reviews are sometimes made stable. This means that they don't require updating anymore. For instance, when a procedure is no longer being performed. For the present review on freeze-all strategy versus conventional protocol for embryo transfer, the protocol was published in 2014. The first version of the review was published in 2017, and an update has now just been published in February 2021. In the conventional IVF-ICSI embryo transfer strategy, the first embryo transfer is, of course, a fresh embryo transfer. In case of no pregnant egg cycle, a frozen embryo can be transferred. In the freeze-all strategy, all the embryos are frozen until the embryo can be transferred. But of course, that's only afterwards, and usually in a next cycle, so it takes a little bit more time. A freeze-all strategy can be beneficial because it may result in increased success rates, as the ovarian stimulation could have a negative impact on the endometrium. It may decrease ovarian hyperstimulation syndrome, OHSS, as HCG, whether exogenic or endogenic, increases OHSS. The previous review did not find a superiority of the freeze-all strategy, but it included at that time only 4 RCTs. Nevertheless, an increasing number of clinics do apply the freeze-all strategy as a standard treatment strategy. And this is also endorsed by many professional organizations. So this is clearly an important review for all of us. So we use standard Cochrane methods. We searched the Cochrane Gynecology Fertility Group and all databases that you usually search in until the 23rd of September 2020. We included randomized controlled trials comparing freeze-all strategy with a conventional strategy, including a fresh embryo transfer in women undergoing IVF or ICSI treatment. Our primary outcome was a cumulative live birth rate. And we defined cumulative live birth rate as the rate of live birth following the transfer of all fresh or cryopreserved embryos within the time horizon of the follow-up defined by the authors of the original study. The primary safety outcome was OHSS. And then there are several secondary outcomes like ongoing pregnancy, clinical pregnancy, time to pregnancy, but also obstetric, perinatal, and neonatal outcomes, as you can see beneath. And these outcomes are very important as they provide long-term evidence on long-term safety for our interventions. So the old search, we were able to include 4 studies, and the update found 11 extra studies. So we included 15 studies in the systematic review, but only 8 studies were included in the meta-analysis. The reason is that 7 studies only presented results per first embryo transfer. The thing is that the time horizon of the 2 treatments is not the same. One frozen thawed embryo transfer can take 1 month more than in the conventional arm. If you see these numbers here, these could be cycles, these could be months. And thus the per embryo transfer results do not represent a fair comparison. Per design, an RCT starts when the couple is randomized. For the couple, the time to pregnancy is very important as well. So the time horizon starts at randomization, so here point 0, until the outcome occurs, or until a preset time point. For instance, couples are treated up to 6 months. This is the risk of bias for all studies here and summarized. Live birth, we calculated odds ratios and subgrouped for cleavage stage transfer and blastocist stage transfer. As you can see, the results overlap. There's no difference in cumulative live birth rate. And you can state that for a cumulative live birth rate of 58% following the conventional strategy, the cumulative live birth rate following the freeze-all strategy would be between 57 and 63%, implying probably no, but if there's a difference, it is likely to be very small. Here for OHSS was as expected, clearly lower in the freeze-all strategy. Another, I think, very important outcome, and well, many studies have written about this, that the freeze-all strategy results in larger babies. So we looked for the outcome large for gestational age, and that was reported by at least a few studies. And well, yeah, so you see that the freeze-all strategy indeed results in more large for gestational age babies, but of course freeze-all also results in less small for gestational age babies. And then we also looked as an extra at birth weight. Freeze-all led to a higher birth weight in singletons, but this was not clear in twins. We also found more hypertensive disorders in the mothers following the freeze-all strategy. So clearly, how we treat our embryos has perinatal effects. In conclusion, there is probably no difference in cumulative live birth rate and ongoing pregnancy rate. Cochrane language is also always very, very carefully stated, but we may say that it is below occurs less often following a freeze-all strategy. So we can state here that the freeze-all strategy prevents OHSS. Freeze-all increases the risk for large for gestational age babies and birth weight. But freeze-all decreases the risk for small gestational age babies. And there's no evidence that freeze-all strategy affects miscarriage or multiple pregnancy rate compared to conventional IVF or ICSI with fresh embryo transfer. Further studies need to report time to pregnancy leading to a live birth with the date of randomization as a starting point, and if possible, median survival times. It is important to have more information on neonatal outcomes per woman randomized, as well as presented per live birth. And in future studies, we need proper reporting of patient characteristics, treatment characteristics, and the protocols used. For patient characteristics, think of women with good prognosis versus poor prognosis. For treatment characteristics, think of the number of available embryos, number of embryos transferred, results for first and every subsequent transfer, as well, of course, time to pregnancy. And concerning the protocols used, I think it's important to look at the timing of the culture, whether an extended culture was used, and the method of the cryopreservation, as well as the method of endometrial preparation for frozen embryo transfer. As a last slide, I show you the blog shot of this review that we used for evidence dissemination. Many thanks for your attention. Be really happy to be here online, and thank you for inviting me at your conference. My name is Madelon Van Wely. I'm a clinical epidemiologist working at the University of Amsterdam, the Amsterdam University Medical Center. You see a part of the building behind.